Okay. Well, I wanted to welcome all of our registered participants today, our panelists. We're very excited today to be having this expert roundtable, the title being Expanding the Impact of Antimicrobial Stewardship. And our experts, as you see presented here, we have basically an all-star cast. I'm going to take you from left to right and do brief introductions. I'm Marnie Peterson. I'm part of the Center for Infectious Disease Research and Policy and have the pleasure of knowing each of these professionals. Starting on the left, Libby Dodds-Ashley, many of you know her and her work. She's a professor of medicine in the Division of Infectious Diseases and International Public Health at Duke University. She also serves as Director of Operations and Liaison Pharmacist with the Duke Antimicrobial Stewardship Outreach Network, also known as DASIN, which many of you probably are aware of that. We also have Arjun Srinivasan. He's a captain, and his current role is he's the Deputy Director for Program Improvement in the Division of Healthcare Quality Promotion at CDC's National Center for Emerging and Zoonotic Infectious Diseases. He's also a captain in the U.S. Public Health Service. And Dr. Elizabeth Monsees. She's also an infection preventionist. She's been in the infection prevention and control field for nearly 20 years, and she's currently the Antibiotic Stewardship Program Manager, Senior Patient Care Services Researcher at Children's Mercy Hospital from Kansas City, Missouri. These three individuals were prior panelists on two other webinars that Carrie's going to give you a little bit of background. In case you haven't seen them, they are available on our website. But really, we took the approach of global, think global, act local. So some of the things that we're going to describe and talk about are our national and global surveillance programs. And Elizabeth's going to bring the act local. How do we implement these activities? And I'm very excited that Dr. Carrie LaPlatte has agreed to be our moderator for this roundtable. She is the department chairperson and tenured professor of pharmacy in the College of Pharmacy at the University of Rhode Island. She's the founding director of the Rhode Island Infectious Diseases Antibiotic Research Program at the Providence VA Medical Center. And there's many other things I could talk about, all four of these individuals. I'm just very excited to have them here. And I'm going to move forward with a few disclosure slides before I hand it over to Dr. LaPlatte. A couple things about continuing education and our sponsor after our disclosures. So as you are aware, if you're listening, you're aware that this roundtable comes with 1.25 hours of CE. So we have some disclosures for you. Pro-CE and clinical care options are our CE provider. And so as far as our disclosures from our faculty and those that participated in the production of this, bringing you this webinar roundtable, there were no relevant financial relationships disclosed, except Dr. LaPlatte has been a researcher for some companies, including Gilead, Merck, Pfizer, or a research consultant for AbbVie. And this is an educational activity. So this is a conversation, this is a discussion of opinions, thoughts, published or in our investigation use of agents. And these are expert opinions and not necessarily representative the view of the planners. And we understand that you as learners have an implied responsibility to use the newly acquired information to enhance your patient outcomes and your own professional development. Target audience is all of you listening: physicians, pharmacists, laboratory professionals. Learning objectives. We aim for you to be able to describe what data are generated and reported in these diagnostic laboratories and healthcare systems, and how is that utilized? How is that utilized to make decisions, distribute resources, and make policies? How are we connecting diagnostic data with clinical outcomes and to our clinicians? Identify appropriate infection prevention strategies based on antimicrobial and diagnostic stewardship data. And that's where we've got Dr. Monsees here in her area of expertise. And then we thank BioMeriU for the educational grant for bringing you these experts as well as this content. CE, ACPE, also physicians, CME, and laboratory professionals PACE program are provided 1.25 hours of credit. This CE can be obtained through our provider, proce.com. I will present this in the chat box at the end and complete. You'll be able to go to that website, complete your online post test, You have 1 month to do this, December 15th. And there's an attendance code that you'll need that I'll provide in the chat box. And before I turn it over to Dr. LaPlante, I just want our listeners to be aware that this is Zoom. So Zoom technology platform, we want you to engage. We've got questions prepared for our panelists, but we want you to engage. We want your questions and comments. So please feel free to provide those through the Q&A or the chat box. With that, I'm going to stop sharing my slides. And I'm going to turn over to Dr. LaPlante.
Thank you. Thanks, Marnie. Thanks, CIDRAP and SIDP for hosting this exciting and important session. I'm honored to be part of these nationally, globally recognized leaders in the field of antimicrobial resistance and stewardship, and appreciate our panelists for taking the time to be with us today. Everyone on this panel has spent their careers dedicated to finding ways to prevent our patients from dying of serious infections, and really excited to dive into some of these more pressing questions. And something we were chatting about before we got on to our attendees. Also excited for World and US Antimicrobial Awareness Week. That's coming up November 18th through the 24th. I missed out. I didn't wear my light blue yet, but I will be wearing it as of Friday. So, all right. So by way of context, as Marnie said, this was a 3-part webinar series. And in this series, the first session that Elizabeth ran earlier this year, it was titled Expanding the Impact of Antimicrobial Resistance Act Locally. And, listen to the presentation. Elizabeth shared a local approach, really talking about antimicrobial stewardship being an evolving discipline, certainly something we have all seen, more broad engagement over the years, which has been fantastic, and that's from the leadership of the CDC. And really a thank you to Elizabeth for being a consistent advocate for our nursing colleagues, to continue to have them at the table. They're critical to the foundation and the role of implementing stewardship. The second series was in September. It was Arjun and Libby. It was same title, Expanding the Impact of Antimicrobial Stewardship, but think globally. And it was really exciting for me to see Arjun's data, sharing the NHSN annual hospital support survey, showing that in 2021, and Arjun, correct me if I'm wrong, 95% of hospitals in the survey were meeting all 7 core elements.
That's right.
Which is a growing trend since you guys started looking at this in 2014.
That's right.
Yeah, so not all these stewardship programs are created equally. You also noted that, and really celebrating how far we have come. And one thing that really stood out, that you had a quote from one of the CEOs, something around, if you want something done, you either need to pay me or make me. So I want to expand on that a little bit more, something we hear too. So first question, Arjun, it's going to be for you. January 2007, the first guidance document from the ID community. It was a collaborative effort between IDSA, ASHP, PIDS-ID, SIDP, and it put forth kind of an institutional guidance to enhance stewardship. It was focused on acute care hospitals at the time. Personally, I have here in my binder from 2002 when I started here at the Providence VA, we were an antimicrobial subcommittee. We were using formulary restriction and treatment guidance based on our local antibiogram. But this kind of foundational document, at least I felt it was foundational and formalized all the work that we've been doing for many years, with a goal optimizing clinical outcomes, minimizing unintended consequences. From your standpoint in your career, what have been some of the successes from this landmark and coordinated effort? And then I'll ask you, where do we need to focus future efforts?
Yeah, I think that's right, Carrie. I think that guideline, was really kind of put a flag in the sand, if you will, and a marker that, here is what an antibiotic stewardship program should look like. And I think there were a kind of growing number of hospitals that had started efforts like this under various rubrics, like you said, an antibiotic. There I guess, had always been kind of antibiotic subcommittees on P&T committees, but mostly thinking about the formulary, right? What drugs should we bring on? How much do we have to pay for this new antibiotic? Is it really worth it? Can we negotiate a better deal on this one if we play it against that one? But not, I don't think, really focused on improving use of antibiotics. And I think that guideline from IDSA really did say, well, we should have formal programs for antibiotic stewardship. They shouldn't just be a subcommittee of PNT. It should be its own thing. And they really were the first group to come forward and say, this is kind of what a stewardship program might look like, and these are some of the things that it might do. And it was a great foundation. I think the one challenge with that guideline is that it was very skewed towards what academic centers could do, right? Because it said you have to have an ID doc as part of the lead, and you have to have an ID trained pharmacist as part of your program. And that's great, right? That is how academic centers run their stewardship programs. But, as things begin to evolve and we began to say, well, we think that everybody needs to have this isn't something that's in the domain of academic tertiary referral centers, right? This is something that everybody needs to have. It wasn't the right model to say it has to be run by an ID trained physician and an ID pharmacist, right? Those staffing categories don't exist at the majority of hospitals in this country. And so for us at CDC, our kind of journey, our real kind of beginning of the journey for us was actually when Tom Frieden said, we were doing a lot of stuff with antimicrobial resistance. And one of the things we said is that, well, we think that antibiotic stewardship programs would be an important part of the solution to antimicrobial resistance. And he said, that's great. What does that mean? And he said, I'm happy to, on this press conference that we're going to have for this antimicrobial resistant, it was about CRE, carbapenem resistant Enterobacterales. And he said, I would love to say that part of the solution to the challenge of antimicrobial resistance is our antibiotic stewardship programs in all hospitals. But you have to define for me what that means, because every hospital needs to be able to have one if I go on and say that everybody should have one. And so that's kind of where this idea for the core elements came from, is what would we want every hospital to have? And what do we think every hospital can both have and do when it comes to an antibiotic stewardship program? So that was the launch of that. We launched that, as you said, in 2014. And when we launched it, we began collecting information through the NHSN annual facility survey on how people were doing with implementing the 7 core elements. In 2014, 40% of hospitals in the United States said that they had a stewardship program that had all 7 of the core elements. And as you mentioned, so last year, 2021, 95% of hospitals are there now. So that's pretty remarkable, right? To go from 40% to 95% in 7 years. And that is quite an amazing reflection of the work that all of you have done, and so many others around the country.
Arjun, thank you. I love that context. It was funny you mentioned perhaps it was very focused in academic settings. There were 13 authors, because I was counting this morning, and looking at each of their affiliations. So nicely represented across the US,
Yep.
Most physicians. We had 2 pharmacists on there were representing well, but I appreciate you mentioning that, because I noticed the same thing. And
Yeah.
the CDC has done a great job expanding that, and we'll get into
Yeah. Yeah. You wonder now, you feel like, if that was going to happen now, what that makeup would look like, right? I bet that committee would be many fewer physicians.
Yep.
It would not just be ID physicians. I would hope that it would include hospitalists and intensivists. It would include nurses. It would include more pharmacists. I think that the representation would be so much broader if we were going to sit down and get that group again together today. And that in and of itself is an incredible reflection of where the field has come.
Yeah, I noticed that too. It's fantastic. And maybe even a patient, right? We're trying.
Yeah.
To
Great point.
Yeah, that's
Yeah.
great. All right, I'm going to move a similar question to you, Elizabeth. Take us through your journey of antimicrobial stewardship in your career from a nursing framework.
Sure. So how I started specifically, is that what you're asking, Carrie?
Yeah, feel free to reflect, from your standpoint, and then you can go broader and I'll ask you, inpatient, to outpatient, to nursing home. But yeah, if you give us a little, to relate to your journey.
Yeah, so my background is infection prevention, and I was actually starting on my doctoral program, and I happened to sit next to Dr. Mary Lou Manning. She was our APIC president at the time, so the Association for Professionals in Infection Control and Epidemiology. And so lo and behold, she sits next to me, and I'm asking her about infection prevention research. And I know I wanted to stay in that space. And I said, where do you envision kind of the next, where I could contribute? And she said, Elizabeth, nurses are really underrepresented in stewardship. That might be an area to explore. The reason I bring that back is I think infection preventionists oftentimes recognize the connection between all of these different elements. So you never know when you're sitting next to someone how you might change someone's career path, which she did effectively. And two, just to be able to kind of help mentor other people in exploring a new topic. And so the reason, again, I bring that back around is because when I think about the role of nurses in that, it is around that interconnectivity of different disciplines and kind of seeing the patient as the center, but so is the nurse. And so that evolution of how stewardship has continued across the different spectrum of care has really been because I think there are so many different disciplines that are contributing to this work in different ways. And so again, mine started out of infection prevention, and has grown since that.
You never know who you're sitting next to in these meetings. You're exactly right.
Exactly. And now she's stuck with me, so she gets calls all the time. So
probably pretty lucky for that. So kind of second part to this question. So over the years, the CDC's led the efforts of stewardship, and they've expanded the conversations regarding the core elements, again, inpatient, outpatients, and nursing home. Where have you seen the biggest impact, from a more holistic standpoint as a nurse?
Yeah, so I think, the CDC efforts really shifted the conversation, as Dr. Srinivasan had said, from prescribing and cost to this really collective safety issue across the spectrum of care. And so I think the biggest impact is the inclusivity of the work. Again, coming from that infection prevention, I think we recognize that practices in one setting certainly impacts in other types of settings. So in an acute, I came from a small community hospital, the patients that we would send from that community hospital to a nursing home and vice versa, certainly you recognize that relationship piece and why different practices need to be a part of that. So again, by including those additional disciplines within those core elements, I think it really added to that engagement. I think the inclusive nature of those guiding recommendations, just in general, that include inpatient, outpatient, nursing home, engages the perspective of traditionally underrepresented clinicians or disciplines, so like nursing, or maybe even settings like nursing homes in particular. I think really having those elements really respects differences. I think it strengthens practices in those different areas. And we talked a little bit about interconnectivity too, but that opportunity for shared learning too. So what makes sense in, an academic inpatient environment and what is resourced for that, and with infectious disease physicians, especially trained pharmacists and such, looks very, very different in ambulatory, in nursing homes. And so I think, having those discrete recommendations helps us leverage different resources or move those agendas forward within our own institutions.
Fantastic. Thank you for that. So Libby, next questions for you. Feel free to reflect on your journey through stewardship, and then I'll kind of ask you more about, some of the successes from this landmark guidance, just as Elizabeth presented on.
Great. Thank you, Carrie. Gosh, my story in stewardship, I feel like it would be a long one. But honestly, it started early on, right out of training. There was a tremendous need to optimize antibiotic use. I was a steward before it was called stewardship. We sort of looked to that new term and to pivot a little bit, but I really feel that helped us anchor on what we were trying to do and gave us more definition to our role. I have done stewardship roles in large academic centers. I was in the inpatient side here at Duke for many years. And then when I was at the University of Rochester, I did stewardship work for that hospital and also masqueraded as a pharmacy administrator for a period of time. which I think helped me learn how to escalate stewardship in the medical center in a way that's actually going to get that top-down leadership support that is so essential to having success. But really got a keen understanding of what it takes to get that. I had reasons why I always wanted to do antibiotic stewardship, and those might not have told the best story, I learned in retrospect. So being able to really speak to leadership is an important skill for stewards. And then now I'm back here at Duke where I get to work in our community hospital network to help further expand stewardship. So I think it's really exciting just to see the progress of stewardship and how it's really now a worldwide initiative. Anywhere in the world, they're talking about antibiotic stewardship, which is pretty exciting when you stop to think about it. We've come so far in a short career.
That's great. Thank you for sharing. I love hearing how people all began and kind of providing context. So, what would you say are the successes from these coordinated efforts, at least through your career? And I think we're in similar career paths here. I think I was a fellow, you were a resident all around the same time. We've seen it grow. We've seen it turn into something pretty big, bigger than all of us. Where are those successes? And then where do we need to focus in the future?
Yeah. Oh, great question. So many successes. One is I think we now have the vocabulary that helps us all talk about the same things. We can now talk to colleagues, and, you walk into a hospital, people are talking about stewardship. I still remember the day when I was in a fully 100% paid stewardship position at a hospital and was in a meeting, and the CEO said, I just got back from a healthcare leadership conference and we need to have antibiotic stewardship at this hospital. Super excited that the words were coming out of the leader's mouth, a little queasy given the fact I was already fully paid to do that job. So I think the fact that people now know what that is, and when you walk into the hospitals, when I walk into my community hospitals, the leadership can tell me who's doing stewardship there. And so, that's a tremendous step forward. So it's a recognized program. When you go into hospitals and you ask to see what their priority goals are, 9 times out of 10, they already include a goal around improving antibiotic use to enhance patient safety or decrease negative outcomes of the antibiotics. So I think some of those are really big successes that we might not always realize, but the fact even that I'm waiting for a proclamation to come out from the governor of North Carolina recognizing Antibiotic Awareness Week. I can't even imagine thinking a governor of a state would even know what I did 20 years ago. So, all those things together by having a focused effort of us all sort of singing from the same sheet of music really has helped us to advance stewardship quite quickly, honestly, over the last 20 years. So very exciting to see those advances. And I think we can't minimize the impact of having these core elements and also expanding to new environments. Again, resource limited settings used to just sort of say, we can't do this and throw our hands up. Now they participate. Nursing homes used to be uncharted territory. We were never going to get in there and do anything. And now they call us all the time for help. And in our community network, they're often asking us to go talk to their nursing home partners who are delighted to have us come. It isn't, we're not sort of wedging our way in the door and saying, listen to me, we got to talk about antibiotics anymore. We're openly invited to participate. And so all of that together, I think, just demonstrates the success of having this consolidated effort to look at stewardship together.
I think a huge change has been that we used to, when we all started, the question was whether or not our facilities, be it a hospital, an outpatient or nursing home, was whether or not we should have a stewardship program. And there would have to be, well, we got to talk to the accountants and we have to do a cost justification and we have to figure out, how we're going to justify the expenses. And now the question is not whether or not you're going to have a stewardship program, it's how, right? So that we've changed the discussion about whether to how, and that is a game changer for anything in healthcare. When you can stop having to, write the budget justifications, and not to say that we don't still have to do some of that stuff, but now, the hospital leadership, it's not an optional thing for them to have, right? You have to have it. And that allows us, I think, now to begin focusing on, well, if we have to have it, how are we going to do it well?
I love that you shared that, because now, at least in our neck of the woods, everyone knows we need to have it. We have it. We're set up. Thank goodness to the NHSN. We're going to speak to that in a minute. And now we just want more. How do we get more? There's not enough ID physicians. There's not enough trained pharmacists. So it's a fantastic place to be in infectious diseases right now. So you're exactly right. So let's pivot to NHSN, because I also think that was pivotal in the development of antimicrobial stewardship. It allows us to compare among facilities, states in the country. And I think most of you guys know, but the NHSN is the National Healthcare Safety Network. So it started from infection control and evolved from an antimicrobial stewardship kind of tool. We have certainly used it in Rhode Island through our state to compare different hospitals. And that's been key for quality improvement for C. diff, among other things. So, I'll start with you, Arjun. You kind of, if you can set the tone with NHSN now, the reporting is now required, and you might want to go back. You talked about that in September, but talk about when it's going to be fully implemented next year, and then how clinicians and antimicrobial stewards are going to best use this data.
Yeah. When we launched the NHSN, the antibiotic use and resistance module within NHSN, so that was launched in 2012. And it was a reaction to what we heard from the experts in the field, right? So we had been talking about doing antibiotic use surveillance within NHSN. And, we brought a bunch of people, a bunch of stewardship experts together at CDC in 2010. And we said, well, tell us what you need, because it doesn't make sense for us to build something that's not going to serve your needs. So what does this field need? And what we heard overwhelmingly is benchmarking, right? Risk-adjusted benchmarking, that is transformative. Look at what it's done for infection control. Look at what it's done for quality improvement. When you can set a benchmark, it allows people to understand how they're doing with use. Because right now, you say, well, our use is 550 days of therapy per 1,000 patient days. Okay, is that good? Is it bad? Is it more? Is it less? And people said, we need some way to be able to say, well, I'm at this tertiary academic medical center and we use 550 days of therapy, but this other tertiary academic medical center, they use 250 days, or they use 950 days. So it gives us at least some frame of reference to understand where are we in the spectrum. So that's, really where the antibiotic use portion of that came from. And, it was built around these standardized antimicrobial administration ratios, where we attempted to, again, working with the stewardship community, attempted to group antibiotics into categories that seemed to make sense for action, right? The whole point of this is, as a steward, you tell us how you would want to group antibiotics in ways that would be meaningful to you, that you might be able to act on. And it is complicated, right? Because you can't just benchmark on an individual agent, because if you're a Pip/Tazo hospital, your Pip/Tazo use is going to look high compared to a cefepime hospital, and it doesn't mean that you're that it's a little bit challenging, and that's why we had to do categories, or why we decided to do categories. And so they're grouped around these standardized antimicrobial administration ratios. How people use that, I think we are still 10 years into this journey. I think we're really still just at the start of understanding how to use that. And Libby can say more. She has really, I think, been one of the pioneers in using this, as have you, Carrie. So both of you, it would be useful for you to comment on your experiences with actually attempting to use these ratios for quality improvement. One thing that we emphasize with the standardized antimicrobial administration ratio, or SAR, is it's not a measure of good or bad antibiotic use, right? It's purely a measure of more or less. Your more might be necessary. It might be good, right? You may have a population that needs more. So your SAR that may be more than one might be perfectly good. That may be where you need to be. And less is not always better. It's merely a way of saying you're more or less. And if you're more or less than the national average, or you're in the 75th percentile or the 25th percentile, you ought to at least look to see and understand, is this where we want to be based on where our use is? But it has grown, as you said, so now more than we crossed the 2,500 hospital threshold not that long ago. It is now a requirement. So by the end of 2024, every acute care hospital in the country must be reporting both antibiotic use and antibiotic resistance into NHSN is one of the core requirements of the Promoting Interoperability Standard that was released in the 2023 CMS hospital inpatient prospective payment system rule. And so, if you are not aware of that, your compliance people almost certainly are. You should be working with them to get your hospital enrolled if you're not already reporting.
Thank you for that, Arjun. I was just reading over that this morning, and we have a lot to get ready for, but it's important. Us here in Providence, we were a beta user in 2013. I didn't realize we were only into it a year. So we have 9 years of data to reflect on. We present it annually to the Clinical Executive Board, Infection Control, P&T. We like that once we get in there, we can pull the data and the tables and the modules. It's been certainly very helpful. Libby, how are you guys using it over there? You have a big network.
Yeah, we use it in different ways. So in our network, we're currently 38 hospitals, but we do include several hospitals that are part of a larger health system. So often those health systems, they're pulling it and looking at it globally at the administrative level. And it's something that it's honestly not too big of a leap to take, because these same administrators are looking at SIR data from NHSN for infections. So it's actually kind of easier to say, this is similar to the infection control data you've seen. It is risk adjusted, and we can talk through the details of that if they have questions, but they do like to see that data in comparative. I think what is actually particularly useful, because part of the discussion around changing antibiotic behavior is we have to convince our providers that what's happening here is different. Because there is this confidently held belief that I do what all my other peers do, whether it be individually or even at the facility level. And so being able to say, this looks different when we compare it is very important. And it's really a game changer. I feel like early on in my stewardship career, we would spend months sometimes just convincing people we had an initiative we needed to even look at. Show me what whoever uses, whoever I consider a comparator to what I do clinically, show me. And it's taken that right off the table. I think of so many providers who say, oh gosh, I feel like this is, I've worked at other facilities. This is pretty consistent with what I see. And I was like, well, there's this adjustment, I can give you this ratio, and this is a 2, and 2 is a lot higher than 1 in this. And so it helps, but also what helps is the distributions. So starting with the 2020 summary of antibiotic use that the CDC put out, and the new one for 2021 is posted on the website. I think it's supposed to be next week, but it's already there. And so it's very exciting, but you can go in there and look at the mean pooled SARs. So basically the nationwide average and compare it, but also on the patient safety portal, it's Antibiotic Awareness Week time. We stock the CDC website. They've already launched state specific SARs, those same pooled mean SARs for states that have enough facilities reporting. You can go in and say, that's fine that your SAR is a 1.1, but did you know that on the average for North Carolina for that category, it's actually a 0.8, which really helps us sort of inspire, because with time, we don't know, as Arjun pointed out, what is optimal, but we only can look and see where we have outliers and then try to figure it out. And I always tell hospitals when I go in, if they have a very high SAR, I say, maybe you figured something out here that nobody else has. So let's look at this together, but it at least gets everyone engaged, and we no longer have to go through the cycle of whether or not we even need to look. That's kind of a given now. So we use it either globally with administrators where that's been adopted. We also use it a fair bit with individual units because, you can get SAR for unit types. Again, no, this is not just every hospital in America. These are other medical ICUs I'm comparing you to. It changes the conversation you can have with clinicians.
And I will say, Libby is also helping us yet again with the SAR. We are working with Libby and the DASON group. They're actually working to kind of pull out use cases to really walk people through, here are real world examples of how people are using the data in NHSN antibiotic use option in order to, monitor or implement or drive stewardship interventions. And so I know they're hard at work on that, probably coming in the next year or so. Be on the lookout for that. I think, as we have all the hospitals in, we do feel like it is part of our responsibility to really try and best understand how to use the data. As I said, I think 10 years in, we're only just now getting to the point where there are enough reporters and enough experience to start doing that. So, we are excited to continue to build on that. If you're on this webinar and you have an example, let us know. We'd love to hear from you.
Thanks for sharing that. Libby, what you say about having the same language with even with our infection control colleagues, I learned so much from them when we were first starting to implement this on how to use it, how to interpret it. And it was nice because they already had the experience and were communicating this with the C-suite, so to speak. So very grateful for that. And Arjun, to your point, I think you hit the nail on the head in that we need those specific case examples. Because we have this holistic data we can compare between states. If any of you have been on the website, you'll get lost. I get lost in, down the rabbit hole looking at us in Rhode Island versus other states. Fantastic high level data, but getting a better understanding and for people submitting on how they use their data, that's fantastic. So I'm excited for that. Elizabeth, I kind of ask you to come into this conversation here. As you've seen this evolve in antimicrobial use in the resistance module as an infection preventionist, where have you been able to cascade this data to your programs?
I think the biggest thing that we've been able to do is still be able to tie it with the resistance data, because I think that's probably the area that in our facility that our administrators, executives have been most familiar with. And so being able to make the comparison between resistance and antibiotic use to really help formulate a picture of how we're performing. So we've kind of tied them in together. We are still, to be honest, we are still kind of working through the NHSN data, only because we've been very fortunate to have a data analyst for many years from when our program started more than 10 years ago. And so we've had internal data. So we're still trying to figure out some of the best ways to use the NHSN AUR data. But yeah, we're basically tying it very closely to infection prevention to give that bigger picture.
I'm going to loop in here doing air traffic control with the Q&A. We have a question from Marcy that I think all of us can answer, but I'll put it to you first, Elizabeth. What are some screening and initiatives you use to evaluate and reduce patients at risk for C. diff? Big topic.
So I'm in pediatrics, so not as much of a C. diff issue. So I should say in my local facility, it has not been as much of a problem. Our biggest area for us for C. diff is our oncology patients. From what I'm seeing from a nursing perspective is oftentimes the history. If we're talking about engaging nurses in stewardship and thinking about the screening of C. diff, what I have seen people represent at conferences and such is getting an accurate history, antibiotic use prior to coming in, and sometimes doing looking at some of those testing procedures to help inform when that test should be done. So that's how they're kind of engaging nurses in that, but not from my own facility, simply because it's just not as big of an issue.
Thanks. Libby, you want to add to that in any way from C. diff standpoint?
Yeah, I think there are a lot of great interventions I've seen out there that stewards have been able to implement, things I think briefly mentioned, making sure we're testing the right people. It's a great place for diagnostic stewardship. So testing people at the right time point, making sure, I know here in the Duke Health system, we've implemented electronic alerts in the medical record that alert providers if they're going to order a C. diff test, like, hey, did you know the patient received a laxative last night? Just ways to help better communicate some of those things. But there are a lot of great resources on this around targeted interventions. And actually our colleague here at Duke, Nick Turner, just finished a huge collaborative looking at this. And I know they're about to have some output from it. And I'm happy to share if people want to reach out in individual targeted things. It could be the topic of its own 1.5 hour long webinar for all the different creative ideas that stewards have put to this. But I really think the top one on the list is diagnostic stewardship.
Thanks. Okay, that's great. So another question here from Janine. Hi, Janine. Are there antimicrobial stewardship certificate programs for nurses? So I'm biased. I wear my hats in two worlds. I know CIDRAP has a great stewardship certificate program. So does MAD-ID. They kind of have some learning. I think, Libby, you're in both of those. You live in both of those worlds, as do I. There's a lot of good components for nurses, but I don't know, Elizabeth, maybe you can answer that. Is there anything specifically for nurse training? Because a lot of us are coming from a community standpoint here, and we need some help.
Yeah, so there was actually a couple published modules. The difference is some of those modules, whether they're inpatient or long-term care, like Robin Jump has done one for long-term care, and that's been very successful to engage nursing of different educational levels in that environment. There was just one published for nursing, and I can tell you Mary Lou Manning has also done some work at Thomas Jefferson University to engage nurses using the SCAN-P module. As far as a specific certificate, no. The certificates that I see most closely aligned are the MAT ID, where I think Elaine Carter was one of the nursing representatives that helped engage some of those pieces. So there's not a formalized educational approach as of yet that I've gone through this program and have demonstrated proficiency there.
Excellent, thank you. So a question here from, let me see if I can find it again, Heather. She'd love to hear some tips for quantifying cost savings. At her hospital, they get antibiotics from a few different vendors, and asking those vendors for price information has been a headache. I don't know if any of you have experienced, maybe Libby, with your big network. There must be an easier way. Any tools that we could recommend for an easier way to get cost information in one place? That's a tough question. Libby, I don't want to put you on the spot, but you might have the answer.
Yeah, I will say it always matters what's going to speak to your financial leadership. So I don't have one universal answer, because we have to respond. We have to listen to what they want to see and respond with it. But what we have found in some of our hospitals that works quite well is we can agree on a daily rate for certain things. And that allows us to apply cost savings or cost to various interventions that we want to do. But this includes, not just counting the drug cost. It includes lots of other things. I saw another question in the chat that asked about determining impact of IV to PO. There are a lot of places that will take estimates from the literature that say a patient on an oral antibiotic will go home up to a day earlier than patients not on an oral antibiotic. And we can all agree on the cost of a patient day in the hospital. And so there are some creative ways to look at those cost savings and to show that impact. The other thing we do is we extrapolate data from the CDC that was published a few years ago now about the impact of reducing broad spectrum antibiotic use on the decreasing impact of C. difficile. C. difficile costs a lot of money to hospital, and hospital administrators believe that. So when you show, look, we've reduced our use of carbapenems and broad spectrum agents by this percent, it's basically 1-to-1 reduction in C. diff. And so this is what we're actually seeing. And look, we actually are seeing lower numbers of C. diff. We estimate this is a cost savings associated with that. That's actually received quite well. We do very similar things in our infection control network on prevented healthcare associated infections. And so it seems to work well. So I think we need to get out of our sort of pharmacist mindset on this and just drug costs and really get bigger on what is the cost of care to a patient. Because, I might not save a lot if I stop a patient on a generic antibiotic, but gosh, if that was generic quinolone and they're not going to get C. diff now and stay in the hospital a lot longer, that means a lot. And that's what's happening. And that's where my time sort of adjacent to the C-suite really helped me. They really do look at things like bed turnover. And so go ask if you can listen in to hospital leadership finance reports. I know whoever wants to go to that presentation, but you'll learn a ton that will be really helpful to you in showing the benefits of your stewardship program to leadership, just a ton.
Libby, I loved your answer. I know many years ago, the biggest impact of our stewardship program early on was the IV to PO switch, and everyone across the ICU, in the hospital, would decrease length of stay by 1 day. We got the metrics at the time for a government bed. It was like 1,900 a day, 3,500 in ICU, and just did the calculations. And at our small facility, we saved millions in 1 year. That was really impactful to give to the C-suite. So money is important. We get it. But being able to translate, I think, is really key. It's fantastic. Libby, I'm going to switch. And
Elizabeth, I think, had something to add there. Yeah.
Yeah, please, Arjun.
I'm sorry, just on the cost thing, the only reason I wanted to bring this up is because I was actually rounding on the units. And I was talking with some of the nurses around, like, again, the traditional things, IV to PO, blah, blah, blah. And they're like, yeah, that's interesting, Elizabeth. But what we're noticing is we're wasting a lot of bags of Cipazlin. This was a post-operative unit. And so anyway, I thought our pharmacist was probably going to pass out at that point. And so, once we've kind of recovered, we basically what the pharmacist had identified, Dr. Amy Wertz, is that our order sets basically were longer than what were intended. So nurses were identifying an issue because they said, this is probably, and so she was able to quantify a lot of cost associated with waste. And looking at antibiotics across the board. So trying to drill into some additional practices that nurses were observing really helped kind of inform some cost data within our own institution too. So that's just another area, just maybe for consideration as.
Thanks, Elizabeth. Arjun, go ahead and share.
Oh, no, I was just noting that Elizabeth had her hand up.
Oh, okay,
Yep.
I missed
Yep.
it.
That's
Thank you.
all. That's all right.
We have like 4 things going here. I'm
I know.
trying-
Yeah. No. Yep.
Excellent. Okay, good. Thank you. All right, Libby, we're going to switch, kind of go back to, you talked in your presentation about global data from WHO is important, but, sometimes we view that the grass is greener. You showed us data from US, Vietnam, Ghana. How do we translate this data so it's more useful to our own programs? It's important to see what's going on out there, but when we bring it back to our own facilities, how do you translate that?
Yeah, I think that's a really interesting question in terms of, and maybe it helps a little bit more at the policy level, those big global reports of antibiotic use. I'll be entirely honest, I don't use the nationwide CDDEP report in my individual hospitals. But boy, I use it a lot when I talk to policy people and to say, like, this is a worldwide initiative and we need to go forward with it. So I think having those data, and especially that we can participate as the US, I also do use it sometimes because in terms of the antibiotic resistance reporting, that's when you look at that report, some of the global data that's out there, we don't always have numbers. We get the regulatory piece because we're committed to submitting the data in, but that's one of the reasons that we really need to work harder to get those global data, for the US to be able to show all the antibiotic resistance rates and track it better. We have surrogates for it, but I think that's sort of the next big step that we'll take. So I think every data has its bit of use, and I don't want to misrepresent it and say that I go into a community hospital and say, let me tell you what's going on in Vietnam. But, sometimes I do go in there and cherry pick and say, this rate of use is lower than this whole country that you you think you have optimal use here. So, just you have to be creative with ways to use it, but they're all great sources. You just have to know their place.
That's great. And I'll ask Arjun the same question, kind of from a holistic CDC standpoint. I do similar than Libby when it maybe policymakers, but, Department of Health, when you look at the rates of resistance, what you presented, Libby, like in Vietnam, with ESBLs and MRSA, I'd like to show how well we're doing because of our formal stewardship programs here in the United States. We don't know what it would have looked like if we never started these initiatives. So with that, Arjun, anything to add to this conversation?
Yeah, I think those are the major points. I think it's always hard. And this is a challenge, I think, for stewardship, for infection prevention. It's always hard to show the negative, right? Because a lot of what we are trying to do is to convince people that something bad did not happen because of the things that we did. And that's a very, very hard thing to show, and oftentimes a hard thing to make people believe. And it's one of the inherent struggles of what we do in the worlds of stewardship and infection control.
Yeah, I'm gonna, let's switch a little bit and address some of the questions regarding ambulatory care settings. So again, I can share my own, I always like context. So we are fortunate, we do well with the NHSN module in our reporting. Our SARS look good, inpatient, we're good. But we all know a fraction of total antibiotic use is inpatient, as 85 to 90% are outpatient. And one of our physician steward champion here always reminds us that with outpatient antibiotic use, we're never going to really show the cost savings. Doxy and Keflex cheap will never, to Arjun's point, show the prevention of hospitalization, because the issue with most of these patients, they're overtreated, and maybe the collateral damage is later on. They're at increased risk for an MDRO, they're at risk for C. diff, which happens outpatient, and we luckily don't see those patients admitted. So with that context from an ambulatory care setting, Elizabeth, I'll ask you first. how might this setting, an AM care setting, and how do you use this data in a different way compared to current inpatient approaches?
And so I think, the biggest thing for the outpatient, at least from my perspective, has been that outpatient stewardship is really where stewardship is playing a supporting role to the frontline providers and seeing what the frontline providers are observing, be that in the urgent care settings, in the EDs and so forth. So for example, in my facility, we do have an infectious disease physician who has some time to be the medical director for outpatient stewardship. She's worked very collaboratively with those urgent cares and those EDs to implement practices such as watchful waiting for acute otitis media and other commonly identified outpatient conditions. They've also been looking at prescribing for acute respiratory illnesses, also focusing, whereas on the inpatient side, when we think about the data that we look at, we're looking at intervention characteristics like stopping, narrowing, optimizing the duration, the antibiotics with the most interventions or indications with the most interventions. Whereas the data on the outpatient side is really looking at, one of the things that has been recently happening within pediatrics is an outpatient collaborative. So they're looking at duration of 7 days or less amongst acute care encounters for certain types of conditions with the antibiotic treatment. And I think the other area that, at least in our facility that we've been focusing on is DEI data too, and looking at prescribing across different sites and individuals that we're providing service for. And then finally, the dissemination of education related to that too.
Excellent, thank you. Turn my mute button off. To that point, I'll open this up to Arjun and Libby. What do you think have been the most effective ways to engage other professionals in antimicrobial stewardship? As a physician, as a pharmacist, how do we best do that?
Yeah, I think that's essential. And I think it was something that we did not spend enough effort on early on. We were very hunkered down, working with ID specialists, working with ID pharmacists, and we did not extend our reach. And I think we did that a lot in infection control as well, right? And again, this is another one of those lessons learned, right? Where for a long time, infection prevention was the job of the infection preventionist. And we shifted that to say, well, wait a minute, no, it's not. I mean, the infection preventionist, he or she can't prevent any infections. Infection prevention is the job of the people who are delivering the care. The infection preventionist is your coach. That's the person who's going to bring the evidence to you, who's going to teach you and show you how to prevent the infections, and is then going to help you monitor to see if you're indeed making progress in doing that. But that's the job of the infection preventionist. And I think we're getting there in stewardship as well, right? The stewards are your coaches, right? They are there to help guide the selection of antibiotics, but they're not prescribing the antibiotics for every patient who's getting them. And I think that it's taught us that we have to connect with hospitalists. We have to connect with nurses. I mean, who gives every dose of antibiotics in the hospital, right? It's nurses. But for a long, long time, nurses were never a part of antibiotic stewardship efforts. So I think we are learning more about how to bring in these other professions. I think the theme of diagnostic stewardship is encouraging us to more and more bring in the microbiologists. How can they help us? How can the lab help us guide people to the right antibiotic and maybe sometimes no antibiotics, or maybe even no cultures through what we do to collaborate with them. So I think you're right, Carrie. I think we have to continue to expand and grow the circle of the groups that we're working with.
Yeah, I love hearing the term coach. That's fantastic. Because that's exactly what we're doing. We're advising on antibiotic use, we're coaching along the way. And it might be received better in different circles than just being a steward, right? Because sometimes you never know how the connotation is. Libby, so same question to you. How are you engaging from an interprofessional standpoint?
Yeah, I think the key there is, so one, I totally agree. We need more people involved. I think some people say like we need more people in the room, and that's where I sort of bristle. I think that as stewards, we need to go to the people. If there's a meeting that they are willing to invite you to talk about their antibiotic use, go to that meeting and start by listening. I firmly believe that healthcare is too hard. Nobody gets up every day and comes in to misuse antibiotics. And you really have to go into it with that lens and tell me, questions much more, not, why are you overusing quinolones, but tell me why you're using these antibiotics the way you are, you'll be amazed at the things that they tell you. There are times where I go in with what is a confidently held misbelief about why someone's using a particular antibiotic. And I find out there's actually, like, I get their logistic reason, and we can back engineer it and change it. Oh, do you do that because it's the easier vial? Or do you do that because you know the quick code for it? Or, whatever it is, listen to why they're using their antibiotics and then design stewardship interventions together. I find that when you start from there, you get a lot more buy-in and you get a lot more success. And once you have a success with one provider, that gets contagious. There's one hospital we work in where we had a group very reluctant to start working with us until their colleagues, their sort of competitor group, had a big win in stewardship. And now all of a sudden they can't get us to their meetings fast enough. So go to them and listen to their antibiotic use reasons before you design the intervention, and that will give you the greatest success.
That's fantastic. I try to tell my team, we try to replace judgment with curiosity. And I realize that when you replace judgment with curiosity, and I've learned this in my own life too, you become more empathetic. You learn more. Exactly to your point, Libby, you listen, you understand, and that's how we can help each other in a much better way. That's fantastic. Thank you.
That's a great quote, Carrie.
Yeah, it's from a podcast, but it's not my.
That sounds like maybe a Brene Brown kind of thing, right? I love it.
It's important though. Elizabeth, we're having a lot of questions. I don't know if you see them in the Q&A about pediatrics. So, where will there be a requirement for NHSN in the pediatric setting? Anything more we can learn about antimicrobial stewardship in pediatrics? Kind of give us a debrief from that, from that standpoint. Libby and myself are all in adult medicine for the most part.
So I think the pediatric and the NHSN, I'll probably defer to Arjun more specifically about that. But as far as the pediatric, there are collaboratives related to stewardship work that are happening. So Jason Newland, who's done a lot of work in this space, has started a SHARPS collaborative. And so effectively for outpatient, about 2 years ago, they started an outpatient stewardship collaborative. And that's where they're starting to do some benchmarking data, looking at duration, less than 7 days and so forth. So those reports are starting to come out within that particular types of setting. There has been some stewardship work as far as another collaborative, so Solutions for Patient Safety had a stewardship component too that is being rolled into some other related components too, because I think it became a little bit hard to kind of keep that as a separate one. And again, the measures are a little dicey, right? Like C. diff is just hard for us to monitor in pediatrics, and that's the common indicator. So there's a lot of work too that is really being discussed around impact scores. I think Arjun kind of alluded to that too. Are we trying to prevent some sort of harm event? And so when we do some sort of stewardship intervention, does that then help reduce the risk of some sort of event associated with it? So there's also some work that's happening in the pediatric stewardship community related to impact scoring. I don't know if that gets to some of those questions, but I'm happy to talk a little bit further offline with pediatric folks if that would be helpful.
Great. Arjun, you want to add?
Well, I'll just note that one of the things that Libby's working on is the use cases are not limited to adult, right? So we're working on use cases for pediatrics as well. And I'll note that pediatrics has been on this journey from the outset. So this is not one of those places where the pediatricians were kind of brought in later. The pediatricians were with us in 2010 when we launched and we had that first meeting. So we have had pediatric standardized antimicrobial administration ratios, or SARS, in NHSN from day one. And those pediatric categories are a little different from the adult categories. And that's important to note, right? So we really listen to what the pediatricians say. For example, there is a SAR category that's a single agent for pediatrics, azithromycin. And they said, look, this is a huge issue for us. We need a category that's just this one drug because it is so important and it's so often a target of our stewardship efforts. So there's a SAR for one drug for pediatrics. So those are there. And then a few years ago, we also launched neonatal SARS. So those are there as well, because there was a very, very big national collaborative led by the Vermont Oxford Network on improving antibiotic use in neonatal settings, and big demonstrations of substantial opportunities for improvement and some really important gains in improvements in antibiotic use in the neonatal community. And I think that's a setting where, I think one of the big impacts that people pointed out was the issue with the microbiome. And I think this is becoming something that it's an unmeasurable right now, unmeasurable benefit of our antibiotic stewardship efforts. But in the neonatal community, they have a little bit more, I think, data where they've studied some of this, showing that, those early exposures to antibiotics can really wreak havoc on a neonatal, a developing microbiome. Marty Blazer has that data where there's some intriguing suggestions that early antibiotic exposures might predispose you to obesity because of what it's doing to your microbiome. So I think there's a lot that's coming there. I'm surprised. if you told me several years ago that like the average person would know the term microbiome or be concerned about their gut health, I would have said that that's nuts. But that's pretty mainstream now, right? I mean, a lot of people are very aware of your kind of gut health and your microbiome. And that, I think, is going to be moving forward one of the huge benefits that we realize with our stewardship efforts. We're not quite to a point where we can measure that consistently, but I think we're getting there, and there's a growing awareness of that importance.
It's fantastic. First I want to go back and note and applaud the CDC for being so nimble when you have these grassroots asks like, look at azithromycin, what do we do in neonatal ICU? Like, that's so important. And, certainly applaud the CDC. And then Arjun, you opened the door to microbiome. Like, we could probably have a whole hour or two conversation on that. So thank you for doing that. Maybe we'll get back to it a little bit. So thanks for that. I want to get back. There's a couple questions about the SAR. And one question, Arjun, if you can take it, I clicked answer this live, is if you can explain the denominator for antimicrobial use AU for SAR, please.
Yeah. So the SAR metric is a measure of the actual number of antibiotic days, so days of therapy, divided by the predicted number of days, right? And that's how we get the ratio, right? If your actual use is the same as what we would predict, your ratio is 1. If you're using more than what we predict, you're higher than 1. And if it's less than what we would predict, it's less than 1. And it's the same as the standardized infection ratio. It's the same concept of all of these standardized ratios, right? I think the oldest one is the standardized mortality ratio, where, it's a measure against unexpected. And so the way that we come up with that predicted number of antibiotic days is through modeling, right? So the statisticians at CDC take all of the different characteristics of all of the hospitals that are reporting data into NHSN, and then they do risk adjustment. They do predictive modeling to see, well, which of these factors is statistically predictive of more or less antibiotic use. For example, we know that the number of ICU beds that you have in your facility is a significant predictor of antibiotic use. The more ICU beds you have, the more antibiotics that you are predicted to use. And so they take all of those different factors that are reported in. It's important to note that these are all facility level characteristics, right? So it's the bed size, it's your teaching status, it's your urban rural location, it's how big you are. It is not at the patient level. It's not how many discharges that you have for pneumonia. It's not how many oncology patients that you have. It's a limitation for us that we don't have that kind of more granular information at the patient level to risk adjust on. So we do that modeling at the facility level based on the characteristics that we have, and that's how we get our predicted number of days of therapy. And of course, the more hospitals that report in, the better that prediction gets, right? So in the early days, it was hard because we didn't have that many hospitals. And so the risk adjustment, those models weren't as precise, but now at 2,500 hospitals reporting data, those models are pretty darn precise. They're getting very, very good. We are continuing to work and explore risk adjustment with patient level characteristics, because we know that that's the gold standard, right? That's where you really want to be. And as our capacity in NHSN for patient level reporting grows, we know that there's a day not too far away where we will be able to capture electronically those patient level characteristics. So we're already working with a bunch of different groups. And again, the DASON group has done some of this work. Group folks at Maryland, Anthony Harris's team has done some of this work. The folks at Kaiser have done some of this work looking at patient level predictors so that when we can get that data, we know exactly what we want to get. And we know from their experience that it does improve. It is different when you add the patient level characteristics in, but I think Libby can speak to some of this. It's not dramatically different. And I think that's the key, is that, is that patient level risk adjustment necessary in order to be able to say, look, this is use that's high enough that I need to explore it. And I think what we have found in our experience is that it doesn't, yes, it changes the ratio, but it still generally is going to point you, even if you just do the facility level risk adjustment, use that's high generally is going to stay high.
That's fantastic. So you did such a good job, because I was able to click off so many questions with that fantastic answer, Arjun. So thank you so much. We're getting some questions regarding screening. Libby, I think that's a quick one. It was directed to you. Do you guys screen for ESBLs or screen for CREs? Maybe that's not an easy answer.
Well, that's a complicated answer.
Yeah.
And it's very complicated because of, so for them, in terms of using it as a clinical tool for patient care, the answer is no. How's that for the quick one?
That's what I thought was going to be quick, but go ahead.
Yeah, but it's very complex and would be, again, it's whole talk into and of itself in terms of the breakpoints that are being used and whether you're using phenotypic screening, and probably all of that is the topic for another day. But in terms of just coming through now that you do have to report some of that to the state, so someone in the microbiology lab is looking at that. And we do sometimes go get those data just to inform. I'll be entirely honest, at some of my community hospitals, I use it to say things to people like, well, I don't know why we're using such broad spectrum agents. We had 3 CRE all year last year, and sometimes that's actually more helpful than putting a percentage on an antibiogram even.
I love that. Thanks for that, Libby. I thought it would be quick, but of course, right. All right, so we're coming to the end of our webinar. I'm going to do a quick roundtable here. And when we all got together last week and talked about how this would flow, I gave you all a heads up that I like to start with context, get into the weeds, and then end with something kind of visionary and reflective. So I'll start with you, Elizabeth. As you reflect on your stewardship experiences, if you could wave your magic wand, it's a term I like to use a lot, what would your wish be for the future regarding stewardship?
So one of the things that I always think back is one of the papers that Arjun wrote talking about stewardship and antibiotics as a community resource. And I keep reflecting back on that. And then there's been other papers that also talk about who's really ultimately responsible for doing stewardship. So when I think about, the work going forward is how can I be involved in the growth of other disciplines? How can I continue to support antibiotic safety efforts? And that what am I doing to raise responsibility and accountability within my own community? So I think there's been a lot of work that's happened. And it's very exciting in this very short window of time. But I think, again, that continued shift, that these small conversations can really have big impact on other people's practice.
Yeah, to highlight what you said, Elizabeth, I think it's getting into the community, having these conversations. To Arjun's point earlier, people are latching onto the microbiome conversation and gut health and prevention of chronic illnesses and immunology. So I share that passion with you, and it's a good timing with antibiotic, World Antibiotic Awareness Week too. All right, next, Libby, wave your magic wand. What could the future look like for antimicrobial stewardship?
Yeah, I've thought a lot about this. There's a lot of different approaches to take, but I think my real dream is when we can approach antibiotic use in such a way that the whole community gets together and works on it. You know, right now, everybody's playing in each other's sandbox. So the veterinarian, the environmental health group, you know, I would love to have the diversity in our portfolio of ways to treat and prevent infectious diseases, that we kind of each could have our own lane and not be bumping into each other so much, that we really had therapeutic options for patients that weren't also being used for prevention. And so I really think of that as combining forces and us all emerging from this as a real concerted effort to optimizing how we approach infection, focusing first on preventing that infection, and using, you know, really antibiotics becoming a therapy of last resort, because hopefully we're so good at preventing these infections from occurring.
Yeah, absolutely. Thanks, Libby. And then Arjun, same question.
So, I mean, I think my desire here is the same for stewardship as it is for infection control. So my dream is a day when the stewardship program and the infection control program never have to go ask anyone or encourage anyone to do infection control, to do stewardship. So my dream is that we are inundated with requests from our colleagues who see the problems themselves and say, I see an opportunity to reduce infections or improve antibiotic use, and I need your help to do it. I would love to see the day when that paradigm shifts completely, and we don't have to go exploring anymore or encouraging people to come work with us or doing cost benefit analyses, because everybody wants what we have to offer.
That's fantastic. Very inspiring. So I thank all of you for your time today, sharing our lunch hour, at least if you're in the Eastern Standard Time Zone. And Marty, are you going to come in and finish this up for us?
Yes, just making sure, Carrie, thank you so much, Carrie, for moderating for us and to our speakers today. Wow, I'm in awe. Well, we covered a lot of content, but I also gathered a lot of topics for the next discussions and the next webinars that I think are very, very critical. So we touched on quite a few of those, whether it be screening, microbiome, interdisciplinary efforts. So can you see my screen, Carrie, where I've got the attendance code up there for our participants? So I post that just as a close. Obviously, people need that number there. 11152022 is today's date, so you can use that to go collect your CE. And I know there were a lot of questions. I really think our participants, Carrie, did a great job of trying to look across a theme of the questions that were coming in, so we could target and answer some of those very broadly. And continue to look towards the future. We did post, those of you that are still participating and are online, look at the chat box, because Libby asked us to post on the CDC links to the reports. So please grab that. What else can I say? I want to thank you all for your efforts, for your time today. Really was an all-star panel of individuals that are leaders in the field. I look forward to the next, like Arjun said, it's been 8 to 10 years. So what does the next 8 to 10 years look like? What a difference 10 years will make. So I appreciate your time, and I will close. Carrie, anything left for you?
No, just gratitude for you for putting this together, Marty. This is fantastic. We've all known each other for many years. We're all working in our silos and bringing it together. Thank you all.
Yeah. One thing that touched me when Lydia was telling her stories, we were doing the job before there was the term steward. So, we continue to push these efforts forward. And I've seen so many opportunities and careers be formed around this concerted effort, which really makes me very happy. Especially the interdisciplinary work is tremendous. So just a few thanks. I did want to, Carrie acknowledge this, but this was a coordinated effort between CIDRAP team and SIDP. So very much thank the SIDP team for helping us coordinate speakers. And we've got a couple past presidents on this panel as well, with Carrie and Libby on this panel. So that's very important to us. And also thank Bob Marion for their educational support to bring this all to you. And we look forward to more in the future and hearing more from all of you. Thank you.
Thank you all.